Now I request the organizing chair of the conference, Dr. Dilip Singh Sisodia, to present a brief profile of Dr. Nene. Sir, please.
Thank you, Shanky. Good morning once again to all of you. And it's my proud privilege to share about Dr. Yogesh Nene. Dr. Yogesh Nene is a medical professional doctor who is presently on sabbatical from his position as a regional medical officer from Food Corporation of India, which is an Indian central public sector enterprise. And he took complete his post-graduation in anesthesiology from prestigious All India Institute of Medical Sciences, AIIMS Raipur. Prior to his present job, he was worked in various central government organizations like Indian Railways, Nuclear Power Corporation of India Limited as a medical officer in various capacities. During his academic years, he has co-authored and published clinical case reports in medical journals of repute, presented posters in national level conferences, and another of his original research is under consideration for publication. He has developed an active interest in the field of AI in medicine and healthcare and is looking forward to studying further and contributing to this field, particularly as a team member from medical sciences. On this note, I would like to welcome Dr. Yogesh to deliver the keynote title. This is on artificial intelligence in medicine, frontier beyond horizon. Welcome, Dr. Yogesh. Thank you very much for joining us.
Dr. Dilip.
Yes,
thank
now
you
floor is yours.
Thanks for the kind words of introduction. Before we proceed, can I make a small request, please?
Yes.
Actually, the audio output from my desktop, where the presentation is lying, is not working properly. So I have logged in using my mobile also under my full name, Dr. Yogesh Nene. So I request you to kindly allow me to share the screen from my desktop, which you are seeing right now. Okay, but allow me to utilize the mic from my Android device, which is under my full name, under the list of participants, Dr. Yogesh Nene. That way, maybe.
But your sound, Dr. Yogesh, if it will be great if you can.
No, I'm microphone. You're able. Yeah. I'm audible because I'm using the headphone from my cell phone actually.
Okay, so please be loud. No problem. You are audible, but try to be loud so it will be audible to all.
Okay, I will try to be loud.
Yeah. You can share your screen.
Okay, I will be sharing my screen now.
Yeah, please unshare this. Yeah, Dr. Yogesh, now you can share your screen.
Yeah, just a minute. Is it visible, Dr. Dilip?
Yes.
Okay. Is it visible in full view now?
Yes, it's perfectly visible. Just try to be loud because it may be with me. I'm getting slightly lower voice pitch. So all are requested to mute yourself so we can hear.
Okay. Kindly allow the speaker, Dr. Yogesh Nene, among the list of participants to keep his mic open, please.
Okay. Thank you, Dr. Yogesh. Please continue.
Good morning, all, and thank you very much, the team MISP 2022, for allowing this great platform for me to share some of my viewpoints, which I tried to observe during my academic years at AIIMS. And I am really thankful to be interacting with all of you and to be a part of this august and highly successful academic gathering. So congratulations to the entire team. Now, I would like to begin. The topic for today's talk by me is artificial intelligence in medicine, which is a frontier beyond the horizon. So before I proceed further, let me put forth some disclaimers that the views presented in this are purely for academic purpose. And as I'm part of Central Public Sector Enterprise, this talk is in my personal capacity and does not represent the views of any institute to which I belong or to any governmental or quasi-governmental organization or any NGO, the images depicted in few of the slides here, that does not promote any medicine or any medical equipment brand in particular by any
Sir,
company.
excuse me, you are not audible.
Uh,
Sorry
am I
for
audible?
it.
No, it's all right. All right.
Sir, you are
Am
perfectly audible.
okay.
You are audible, sir.
Okay, fine. Can I continue, please?
Sure, sir.
Yes,
Hello?
sir. Yes, sir.
Yeah,
Yeah,
please
thank you.
continue, Dr. Yogesh, and try to do it if possible. Please be loud only, or otherwise you are audible perfectly. No problem.
Okay, okay. Thank you,
continue.
thank you. And I didn't receive any financial grant or remuneration. So with this, let us begin. So what is a frontier beyond the horizon? What was my idea about this? We all know that frontier is something, the extreme limit of understanding or achievement in a particular area, whatever may be that field, medicine, engineering, space, whatever. And horizon is a line at which the earth's surface and the sky appear to meet. They are not meeting there actually, but it's apparent that they are meeting over there, right? So the artificial intelligence in medicine or healthcare is a field in which there is actually no visible limit to which the knowledge will advance, and the applications to the benefit of humankind will emerge out of your contributions and a teamwork between the medical fraternity and engineering fraternity. So with this, let us see how, what is a medical practice in general. How does healthcare happens actually? As we all know, I mean, in one capacity or the another, that medical practice traditionally, it encompasses the living beings which are interacting with each other. There is a healthcare personnel who is speaking to somebody who is in distress, who is having some kind of health issue. He is trying to find out what has happened, which we call as history. The patient or the person who is having some issue is clinically examined using the our sensory organs, and then some probable cause of what could be the reason, what could be the probable diagnosis is is considered into the mind. With that, some investigations are ordered, and a medicine or a surgical process, whatever is appropriate, is prescribed to the patient. And then after all of this, some result comes which are along the expected lines or which may not be along the expected lines, and therefore the patient and the entire approach is revisited. So it's like a continuous process. It's not a single stop process, right? So how did this quest begin? Say a patient comes to a doctor, and they are interacting with each other. So once you are seeing the patient physically, and after getting the history or some idea, say the patient says, oh my god, doctor, I have got a pain in my, say, upper arm. Okay, so now the natural quest which comes to your mind is it possible for us, a healthcare personnel, can we see over there? Then second question, suppose we are able to see there, can we know what is happening actually, whether it is a fracture, whether some blood vessel has been occluded, whether due to some blunt trauma a blood clot has formed and is compressing the neural structures over there, something like that. And if we are able to see there, or we know what is happening, so is it possible for us to intervene somewhere for betterment of that patient? So in this way, uh, traditional medicine has always received help from the biomedical engineering side, from the engineering side, from the technological perspective. Now, for example, look at this first X-ray image. This is the image, classical X-ray image, which William Röntgen he obtained on his spouse. Okay, so maybe this was one of the first endeavors whether you can actually see what is there, right? Now, thankfully, as the technology has advanced, is advancing day by day, we know what is happening. For example, we can see in the real time. Uh, this is an image of an echocardiogram, 2D echocardiogram. Okay, so when I say a 2D echocardiogram, it is basically a real time image of the activities which are happening in the heart. the blood is continuously coming into one of the chambers of the heart, the atrias, and it is being pumped into the pumping chambers called as ventricles, from whereby it is respectively being pushed up along the systemic arterial circulation, or is being pushed along the lungs for oxygenation and purification. We all know this thing. So thankfully, now we know what is happening also besides seeing them, and now we are able to intervene also in the backdrop of technology. Say we have got a patient who is a case of blockage of one of the arteries of the heart called as coronary arteries, which supplies the myocardium. So we know that mostly the heart attack is happening because there is some blockage into one of the feeding coronary vessel, and that results into the myocardial infarction. So because of the technique called angiography, which is essentially an imaging technique, we are able to visualize where the clot is located, and now we are able to intervene. As one of the fraternity doctor called as cardiologist, he would be passing a device called catheter. He will actually reach to the site where the obstruction is there. Can you see this plaque into the blood vessels, the yellowish colored? And he has passed on a catheter and a stunt. He has inflated a balloon, and he has managed to break that plaque, right? And after this plaque is broken and the obstruction is removed, now he has managed to put in a cylindrical device called stunt, so that further onwards the blood flow will continue to happen. So we have been able to intervene for the betterment of the patient. So as I said, the technology is helping in better patient management. I quoted some example like it's giving a real-time picture like ultrasound and 2D echo. Also beat to beat heart rate, as you all of you must be aware, during these COVID times, this pulse oximeter was quite in vogue, and images of the body organs like X-ray, CT, MRI, etc. Now, as I discussed, our companion in COVID-19 pandemic alike for the healthcare personnel and the home surveillance patient, the pulse oximeter. Now, the beauty of this technology, see how easy it is to use even by laypersons. Comparatively, the cost is less and is quite informative, because you are able to see what is the saturation of the oxygen based on which people used to seek the medical attention. That is, a lay person could also understand, okay, my disease is now heading for worse, maybe it's the time that I should now get myself admitted. We are also able to see what is the heart rate, and for a trained and skilled health personnel, doctor or a paramedic in critical care, this arterial waveform is also there to help us out. So this is a classical example of something which was a highly useful technology, right? And is there. Take for example another very commonly used imaging device, or rather a bioelectrical device called electrocardiograph. Now, all of us must have come across this ECG strip somewhere, sometime in our lives, either as an attendant to one of our near and dears who has been taken to the hospital, or maybe ourselves also. What is it? It is basically a graph. It is basically a graph between the bioelectric current which is being generated into the heart against the time, right? So as you can see, on the y-axis it's the millivoltage, and on the x-axis it is the time in second. So this little piece of graph is so much informative that it helps lots of healthcare personnel all around the globe to take the timely decisions and to see how they can treat the patient better. Another case in the point which all of you I'm sure are familiar with is an electroencephalogram, nothing but an electrical recording of the brain's electrical activity, and is highly informative towards the diagnosis of seizures or epilepsy. So this is how the technology has been a game changer to us. Now, after having discussed all of these things, we know that most times we are able to see. Many a times we are also able to know what is happening, and sometimes we are able to intervene also, but all this is in the backdrop of the availability of the resources, skilled manpower, financial circumstances surrounding case to case basis, and so on and so forth. So the quest continues. The desire for something better is keeps going on. And this is what is the next question which comes to all of our mind. Now, can we try to have an idea how the things or events are likely to happen for an issue under consideration? We know, okay, something has happened. A patient has sustained an injury, he has sustained a fracture, he has undergone an X-ray and has been diagnosed to have a fracture at, say, a particular bone, and a conservative treatment, plaster of Paris bandaging, or a surgery leading, which you call internal fixation, has been undertaken, and patient is likely to be better now. Okay, this is a very simple case scenario, but there are many complex scenarios in the medical science in which we actually want to know how the things or events are likely to happen, right? So, as we discussed, past is a gateway to the present. Without yesterday, there could not have been a today, and without today, there could not be a tomorrow or a future. Why? Because in general, to try to have some idea as to what is likely to happen next, how events are going to unfold in the future, we take the help of the past. How? We try to take the results which are obtained from the previous or past studies conducted for any given case scenario. Also, we try to go for what you call a meta-analysis of previous data, the sum of all or most studies taken together, relevant one, and that gives us some answers. For example, say in 30 such previous patient of some medical condition, heart attack or sinus tachycardia or pneumothorax or whatever, appendicitis. Something X has happened for the given situation, and when medicine or a treatment modality, a surgery Y was instituted in respect of that patient, some Z result was obtained. Something has happened, some result has come. So therefore, in again we are facing the similar situation, and now if we do the same thing, we give either the same medicine Y or take up the patient for the same surgery Y, we are more than likely to obtain a result Z, and it is acceptable, say, for that given scenario, or may not be acceptable for that given scenario, which is a very remote possibility. Okay, so this is how we try to tape on the experiences from the past. Okay, so now when a healthcare personnel is facing a patient, what are the different data, different variables which are coming into his mind vis-a-vis the clinical presentation of the patient to come to some meaningful conclusion, so as to start moving forward step by step. There are many factors. These are just some of the examples. Say, for example, patient might be diabetic, so what have been his fasting or his or her fasting blood sugars? Is he having any other comorbidity? Is he a case of thyroid disorder? Does the patient has a coexisting bronchial asthma? What were his X-ray findings yesterday X-ray? What was his X-ray like 1 year before? Does he have an ECG right now? Did you took out an ECG? Okay, what is this ECG? Acha, acha. 6 months back, he also had the similar problem. That time also ECG was taken. What were those ECG findings? Is there some change between the previous ECG and the present ECG? What is the serum cholesterol? Is he taking any medication for that? What is the patient's weight? What is the patient's height? So many things. Is the patient a Caucasian? Is an Asian? Is an Afro-American? What? So this is how the brain tries to work, right? So you have some X-ray in front of you, you have some background history of the patient, you have some present clinical condition of the patient, and you try to come to some conclusion, right? So all these elements are like perception of the operation, the cognition, the medical image interpretation, and some complex decision making by what? By this integrative data analytics. All of these things were taken into consideration. For example, say a child, say 2 years old child or 3 years old child, suddenly presenting to an emergency with a history of difficulty in breathing and uh, uh, I will come to that later also, some abnormal respiratory sound. Okay, so what would be the first diagnosis? Now definitely you know, most of the people would not take that diagnosis to be something like some space occupying lesion in the lung. No, most common thing would be like, say, he or she has popped up some foreign body, could be a peanut, could be a coin, whatever. So this is how the past experience and the present clinical condition of the patient helps to come to some kind of conclusion for a healthcare personnel, right? This is a chart illustrating how, in general, for all of the things in life, for all of us, the brain tries to process. We have some well-defined problems. There are multiple factors, F1, F2, F3, F4, out of which some ideas 1 or idea 2 may come, which again are weighed in by the brain, and then one or few of them may be rejected or accepted to reach to some simple correct answers. But what about some open-ended problems? There might be many contributory factors towards origination of that problem. There might be many ideas popping out of that complex decision making algorithm, and there might be many possible answers coming out of that, but which may or may not be correct. One of them may be correct, more of them may be correct, none of them may be correct. So this is all how it goes, right? So problem is this: there is a multiple data which needs simultaneous, given instant of time, simultaneous and faster processing, and it needs to be more and more precise. But fortunately or unfortunately, we as human beings, as we all know, are prone to what we call fatigue. We just tire out after a long shift, after a long break. All of us, some of you are working, sitting in front of computers for hours altogether. Your mind tends to get fatigued out of some hours working, and then maybe when you take rest and then you revisit the problem, some solution comes out to you. So this is a fatigue. We may be biased, what I'm thinking is correct, right? But what you are thinking is not correct. No, I don't accept. So answer, as you all know, is artificial intelligence. So what is AI in medicine or healthcare? So it's basically an umbrella term, it's an overarching term which is used to describe the use of machine learning algorithm and software or artificial intelligence. Okay, so what it does basically is to mimic human cognition in the analysis, presentation, and comprehension of the complex medical and healthcare data, which we discussed. So specifically, as they say, it is the ability of the computer algorithms to approximate the conclusions based solely on the input data. And from what I gathered, it's like Mr. John McCarthy, who first described this term AI in 1956 in the engineering sciences in context of making the intelligent machines. However, let us go back to some case scenarios in this regard. Now, having discussed how traditionally medical practices is undertaken by and large all over the world, and having traveled through the journey of how technology is helping the healthcare personnel, now let us try to discuss some specific case scenarios. So let us take the example of a very simple device called stethoscope. All of us, all of you must have seen it. There is no doubt in my mind. How did it begin anyhow? It all began when this good doctor Rene Lenac from France, uh, he wanted to listen to the sounds of originating into the chest, or what we call respiratory sounds. So these were the like 3 400 500 years back, medieval times, what we like to call. So therefore, what in your terms, in engineering terms or in physics terms, what he simply used is hollow wooden tube, and he used it to listen to the sounds using one ear only. So this design was a hollow wooden tube that was mono, single oral ear, mono oral, and 1800s. So basically, what is it? It is what you like to call an acoustic device, and it transmits the sounds from the chest piece. The portion which is kept over the chest is the chest piece, through an air filled hollow tube to the listener's ear. This is what stethoscope is all about. Okay, so it again started evolving. Before that, let us see what is when a doctor is listening to your chest. That is called as auscultation. What is it basically? It's listening to the sounds more generally from lungs and heart and other organs like stomach or blood vessels, typically with a stethoscope as a part of the medical diagnosis, right? We all know that. Why? What is the reason behind? Say this healthcare personnel or Dr. Rene Lenak was trying to listen to the sounds in the chest. So that sound serves as a data, as I understand for my engineering colleagues. It is a data. Okay. How it is getting produced? It is produced because air which is surrounding us is continuously trying to move in to the lungs. So since air is a fluid, it will flow. So that is fluid flow. And we all know when the fluid flows, it can have either a laminar flow or streamlined flow, as you can see in the picture, or it can have a turbulent flow, right? When the flow is turbulent and when the Reynolds number it exceeds 2000, what is happening is the generation of the eddy currents, or otherwise called, which are picked up as noise. So this is the abnormality, or this is the reason why the respiratory sounds are produced, and because of different health conditions of the lung and airways, like for example trachea, for example the bronchi, for example the terminal bronchioles. This is the path which air takes is an airway in the body, right? So any problem, any pathology along this tract might lead to change of the flow dynamics, and it would result into some kind of sound, either normal or abnormal, which we try to pick up, a healthcare personnel tries to pick up. Say suppose a healthcare personnel comes across some scenario. Okay, he finds that, oh my god, this patient, I'm not able to hear any breath sounds when I put the stethoscope on the patient's chest, or there is a decreased air movement. So we know that, oh my god, it could be either the air has come in between the lungs and the chest wall, or there maybe the patient has met with an accident which we know through history, and the patient has a collection of the blood which is just above the lungs into something called pleura, and that is reason why there is no sound audible. There might be airflow, there might not be airflow, but sound is certainly not audible. Okay, a patient is making an extra effort to breathe and is using the muscles present in the chest, right? So there is a necessary muscle use. Patient is trying to really breathe in very hard, and he is in what we call respiratory distress. So, oh my God, this patient needs urgent mechanical ventilation. He should be given a ventilatory support either through the non-invasive ventilation, the mask, which most of us know because of COVID, or patient needs to be put on ventilator, and so on and so forth. So as I gave an example to you previously, the patient is having some abnormal respiratory sounds when the patient is trying to breathe in. Okay, this is not a normal sound. This is an abnormal sound. This is a child. He has taken up some foreign body, or is suffering from diphtheria, and this is the reason why his epiglottis is swollen, or patient has had a bee sting or some poisonous sting or some kind of drug allergy, which has resulted into the swelling of the airway, and this is resulting into abnormality of the sound. That is what patient is suffering from. Likely, let us start giving something to, let's give some adrenaline nebulization, give something like that, xyz, give some treatment and try to take the patient out of it, right? So this was just a some cases in the point, some isolated examples. Now, you have seen a simple wooden monooral tube, and you, most of you are familiar with this picture. All of you, I'm sure. Okay, something stethoscopes do tend to look something like this. Okay, except that now there are two earpieces, and the chest piece is more well defined, and this hollow wooden tube is replaced by a rubber tube. But nonetheless, it still essentially remains a hollow tube, right? Now, next advancement came in the form of what you call electronic stethoscope. So, what was new into this? What betterment has the technology has done for us? What is happening is the sound which was being picked up by this chest piece. Okay, now with your help, it can be the amplitude of the sound can be magnified maybe up to 20 times, right? So a simple low intensity sound, which was sometimes difficult to be assessed by a healthcare personnel, is now coming to him or her in an amplified form, so that he has a more better and clear uh, appreciation, and is probably uh, in a better place to take a better decision, right? This is another advancement which has been so much helpful to us. So what next? uh, Problem is that, as we all know, auscultation is something, or listening to the respiratory sound is something which is usually undertaken by a medical personnel or a paramedical personnel in general for the treatment or health examination purpose, right? And therefore has a learning curve. You need to spend some time with some backdrop of theoretical knowledge, and some effort has to be put in and to be discussed, and the nuances of the variations need to be understood. But what is ultimately the thing which we should not forget? We should never forget that this is a subjective perception, right? Therefore it is based on experience, based on the, what do I mean by experience? A senior doctor to me, say by 20 years, would be able to just keep his or her stethoscope on the patient's chest, and would be able to instantly form a diagnosis, would be instantly come to conclusion, right? But it might be difficult for me, it might be probably more difficult for um, a first year PG resident, and probably be very difficult for somebody who is in say uh, medical or nursing or some kind of basic graduation training, right? Also, suppose I have some hearing problem with my ear, my I am hard of hearing, what we like to call, okay, or there might be some wax in my ear. So the sound is being generated all right, it is being picked up all right, but I'm not able to, or the healthcare personnel is not able to appreciate it all right. That is subjective. Another thing is, the people who are being subjected to this examination, or the lay persons or the patient, they themselves are not able to perform or understand what is being done for actually, right? And most important of all, particularly in the backdrop of COVID, sometimes it is difficult due to PPE to access, right? We all had access issues in COVID-19, the healthcare and paramedical personnel, not to mention the public in general, while taking uh, travels and all those things, sometimes PPE was there. So all of us know that it actually creates a lot of problem in better working, right? These are the issues. So therefore I came across this study by Thomas Grzewalecki et al., titled "The Fully Interactive Lungs Auscultation with Artificial Intelligence Enabled Digital Stethoscope." So basically, what in this study uh, they had some pre-recorded sounds, okay, and they had designed a stethoscope. They had devised a device which the patient could keep on his or her chest at the predefined points of auscultation or the points of listening. So normally, as a healthcare personnel, there are 12 points on which the stethoscope bell is kept, and the sound coming is tried to be picked up. But this AI enabled digital stethoscope was wonderful in a way that it only required 3 auscultation points to be able to come up with a diagnosis as to what are the possibilities in this case scenarios. Moreover, it could actually guide the patient in an interactive way where to keep the stethoscope bell next. Say patient has kept it on right side of the chest in upper portion. So once it has picked up some sound from there, it will guide the patient to okay, you keep the stethoscope bell now here, right? And only by 3 such efforts it could come to some wonderful conclusions. So This is one very good study, and this demonstrates the power of, or what we like to call, there is no limit to what can be achieved in the field of healthcare for lots and lots of human beings, right? So what is the need of the hour for our country in particular? There are a large number of patients, right? We are second most populous country in the world, and we know that at peripheral levels, at village levels, the expert health services needs enhancement. Okay, at peripheral level, a quick and timely detection of correct diagnosis by both medical and paramedical staff using a device of this kind may actually help with the early optimal treatment of the patient and timely referral to a higher center if such is the case, such is the needed. Now, thankfully, since our country is having increasing affordability, literacy, internet connectivity, and smartphone reach, both in urban as well as peripheral settings, if we can have this kind of device, right, for auscultation of the patients, it can also be used for self-monitoring purpose, as I said, seeking timely help, and more important, as an important component of telemedicine. Suppose it is not possible for the patient to physically travel from one place to another, but through the use of technology, through the use of AI, if somebody is sitting in city and is uh, conferencing with a patient at remote level, is able to actually know what is the sound which the patient is right now having in his chest, he or she can actually say, okay, probably this is so and so, maybe you can try giving him this medicine, or maybe you can try changing the position of the patient from this to this, or maybe you can nebulize the patient with this and this medicine, so on and so forth, right? Or, oh no, I think this is something X, you try and convince, you try to figure out how fast the patient can be transported to us or to the nearby uh, higher level treatment facility, right? So this is what kind of technology is needed, and this is where the technology has expanded. However, for all these things to actually be of benefit, there is always the cost factors, there is always the ease of use. Okay, a device of this kind should have minimal auscultatory points and minimal interpretation time, right? It should be able to give the interpretation pretty fast. Design may or may not resemble a stethoscope. Ideally, due to smartphone connectivity and literacy and awareness of the beneficiaries as well as the service provider, could be linked with an app, some graphical display could be added, and some interactive and regional language features could be enabled into such kind of device, if this kind of device has to work at all. So this is one of the scenarios which can actually be really helpful for a large number of patients, large number of human beings. Let's venture to critical care areas or intensive care areas. As I said earlier on earlier occasions, if not all, some of us have exposures to intensive care units, either as an attendant to one of our near and dears, or a friend or colleague or whatever. So when we think of an ICU, the first image which comes into the mind of most of the persons is a patient who is bedridden and is surrounded by a lot of monitors and gadgets. What are these monitors actually doing? They are giving a continuous real-time basis heart rate values, respiratory rate values, saturation of hemoglobin percent, and blood pressure, for example. These are not the only parameters, these are some of the examples of the parameters which are being real-time monitored. Okay, and point to be noted is that they require a continuous monitoring, which can mostly, which is undertaken manually. There is always some doctor who is looking at the monitor, is always taking a round, or a nursing staff who is attending to the patient, or there might be some electronic sensing system or something like that. So if uh, before that, let's come to this next image. This is the image which most of us are familiar with. So this first is an ECG strip, continuous ECG. The image, the line at the bottom one is the respiratory wave graph, and this 20 is the respiratory rate of this hypothetical patient in question. This 98 is the saturation of the hemoglobin. This 120 by 80 is the non-invasive blood pressure of the patient. This 60 is the heart rate of the patient, and this 37.7 and 37.2 might be the temperature. Okay, so some sensing is ongoing. And let's get back to the previous slide. If any abnormal value, say this heart rate drop down to 40, an alarm beeps. Some irregularity of the waveform, somewhere here this gets elongated, or this shortens, or this longens, okay, or this value drops down, something like that. This generates some kind of alarm audiovisual signal and is attended by the personnel for needful corrective action to be taken if warranted at all. Okay, this might be sometimes false reading also. Patient has moved, okay, his hand or her in some direction, and that has led to some kind of signal generation which has been falsely perceived as being abnormal. So that is where the role of healthcare personnel comes in such a scenario. However, can it be taken one step further? How? Say most of us ask the question when one of the patient is admitted in ICU is, what is the patient's condition? How it is going to progress? What do you think? I mean, how the patient condition is going to progress? So what happens is, in general, based on the clinical condition of the patient and some scoring systems, the medical scoring systems, like say acute physiologic and chronic health evaluation score, or sequential organ failure assessment score, etc. So all these things, okay, the condition of the patient, his admission time, vital parameters, his admission time or shortly after the admission time, investigation values, and the course of the disease, the pathophysiology of the disease, the epidemiology of the disease with which a healthcare personnel is familiar with, has understood during the academic years and practiced it. Based on all this combination, a general idea of the prognosis most of the time is obtained and is considered, both for the treatment purpose and to coming to some decision. So, is it possible to perform the analysis of different parameters, like say heart rate, say blood pressure, say the patient's level of consciousness using this Glasgow Coma scale, the temperature values of the patients, the serum creatinine values, for example. These are all isolated examples. It's not a complete cluster. How over the period of time and in the backdrop of the present clinical conditions, when the treatment which was evidence based and as per the established medical protocols was given. So can artificial intelligence here help to prognosticate? So there are so many factors, so many variables, so much of the data, and is it possible for some of these data to be clustered together to derive some pattern out of it, to come to some conclusion and see how it can help the patient? Let's come to the last case scenario for the purpose of this talk, something called a premature labor. What does it mean actually? It means that the baby in a normal term pregnancy who is born around 37th week is born somewhere between the 28th week of the gestation, but before the 37th week or the term. How does it happen? Why does it happen? There are multiple factors which have a rule actually. Okay, we'll just have a look at those factors briefly. But what is more important is that upon suspicion that such a situation is impending in case of a gravid patient, the healthcare personnel, they often hospitalize this patient, they administer some needful empirical treatment or evidence-based treatment or something, and then the further decision is taken based on the evolving clinical scenario. Does this patient gets, suppose the patient gets benefit, the premature labor contraction gets terminated, okay, and the patient becomes stable now, and the threat that the baby will be born prematurely is reduced considerably due to that treatment instituted, or no, the treatment has not probably been that much helpful, and still there is a risk. So what to do next? So this kind of decision has to be taken, right? Say some of the factors could be urinary tract infection, high blood pressure, vaginal bleeding, certain developmental abnormalities in the fetus, or reproductive tract infections, or some kind of artificial reproductive technique based pregnancy, that is in vitro fertilization, or the patient was either underweight or obese before pregnancy, or the time between two consecutive pregnancies was very short, less than 6 months. Okay, or a condition called placenta previa, in which the placenta grows in the lower part of the uterus and covers all or part of the opening to the birth canal or cervix. Okay, or patient is being at the risk of rupture of the uterus when the walls of the uterus have been open, and suppose this kind of the patient had a uterine growth called fibroid, for which the patient has undergone surgery, or patient is a diabetic, or the patient was not diabetic, but the patient now has developed diabetes during the term of this pregnancy, during the course of this pregnancy, and is like her blood sugars are likely to be all right once the pregnancy is over. So this is a gestational diabetes kind of condition. Or patient could be having some blood clotting problem, low platelet count, or elevated PT or INR. Okay, there's one important thing here. There is something which can be objectively seen and objectively measured through ultrasound in such a scenario. So what happens is, this is the uterus, and you can see the baby's head over here, and this two walls, two dimensions, they are what we call cervix. Okay, this further opens down, and once this entire path is open, this becomes a birth canal through which the baby traverses down. Now what is important, what makes a difference here is the length of this cervix. Okay, so the normal length of cervix in such a scenario should be more than 3 centimeter generally. Okay, so what is abnormal is if the cervical length is less than 3 centimeter, this is a known risk factor. That patient will have a very high chance of premature labor. So the moment a healthcare personnel come across the short cervix condition, particularly after 28th week of the pregnancy, this thing automatically comes, and the, as I told you, the actions start. The point is, there are a lot of factors. The patient, there might be the age of patient could be 32 years, patient could be 23 years, 27, whatever, Caucasian, etc. Patient could have had multiple gestations. Patient is probably having twins right now, or there was a previous history of this kind of uh, mm, premature labor. Okay, so can AI try to predict whether cervix shortens in the second trimester? Now please mind that when I said ki, we had seen, suppose we came across a short cervical length around 28th week of pregnancy, we have a high suspicion. But can AI predict whether cervix shortens in the second trimester, that is through 4th to 6 months of the pregnancy? So these were some of the isolated case scenarios, and I would like to conclude my talk here only. I would like to convey my sincere thanks to the organizing committee and to the audiences for patient listening, and I hope that maybe you can think something about it uh, by a joint effort between the engineers and the doctors, the technologists. Let us see how we can try for the betterment. So thank you organizing committee, and thank you Dr. Dilip Singh Sisodia. Thank you very much, sir. Hello, am I audible?
Yes, sir. So before concluding the session, I request all the participants to please switch on their video so that we could have a group photo. And I request to sir to please stop sharing the screen.
Okay, ma'am. Just a minute. Okay, I cannot see the icon to be clicked over here. Just a minute. Stop sharing.
So just scroll yourself to bottom of the screen. At the bottom of the screen, there will be a pop-up toolbox will appear, and there you can find. Sometimes it may be on the top of the screen as well.
Deepak, can we stop from our end?
So just a minute.
जो सेलर होते हैं,
Okay, I
जो
cannot
सेलर्स
see
होते
the-
हैं,
Now it's done. It's done on my end. I guess it's all also reflected to other end as well.
Yes, sir. It is off.
Yeah.
Now I request everybody to please put on your camera so that we could have a group photo.
Participants, please.
Okay, I'm taking. Okay, thank you, one.
Done?
Yes, sir.
Thank you. Thank you, Dr. Yogesh, for sharing your views on such an important topic. Really, your talk was very informative for us because we are aware about the computational methods, but we don't know much about the domain, how things are going actually in medical field. So thank you for awareing us about all these things.
Thank you, sir. The pleasure is entirely mine. Thank you.
Okay, so next parallel session, technical presentation sessions already started from 12 o'clock.